Kwame Asiedu is here with us after he delivered his public lecture on the health dividends that we have or perhaps have not received in the Fourth Republic. So many things have now started to occupy our thoughts about why we do things a certain way. And Kwame, before we even get into those very crucial indices of maternal and child mortality as well as life expectancy, before we get into those, you pointed out the absurdity of public health administration in this country. How at any given time, only half of the public health expertise of this nation is available, because the other half is basically shut out because of winner takes all partisan politics. I mean, just for those who perhaps might be tuning into this idea for the first time, help us understand the effect of a nation shutting down half of its brain when it comes to managing healthcare.
Thanks, Kojo. It comes from the point of what we term groupthink. Normally, for any society to improve, whether it's healthcare, anywhere, you need divergent opinion at the table, because that brings rigor to the conversation. But what we see is, because of the way our politics is structured, both political parties have between 44 and 46% of the popular vote. You cannot shift it. The data clearly shows since about 2000. Whatever you do, they'll get about 44%. So what happens is that 10% in the middle, that are the kingmakers. They are the ones who either sway this way or that way to get people to win an election. But when they win the election, appointments are by loyalty and contribution to the political party, whether you have a party card and all that. And you must bear in mind that even that 45%, not all of them would have party cards. So in actual fact, the pool is smaller than the 45%, but I just wanted people to appreciate it. So what then happens is you are going to appoint from these people. And when it comes to working as a technocrat, it's competence that matters and not loyalty. So when you go and pick all these loyal people, they are people who think in a similar way. And therefore, that rigor that is required to bring out robustness in delivery is lost. But more importantly, the other 45% plus the 10%, the 10% just go and sit on the fence. They are the ones who say, oh, me, I'm working as a doctor or a pharmacist and I don't want to be tainted with any politics or anything like that. So they sit on the fence. The other 45% spend their time pointing out what this 45% is getting wrong and make it clear that the minute they come, they are going to jettison everything that these 45% were doing and start all over again. So you have the situation we see. And if you want to see it vividly, look at our infrastructural projects. You'd see that somebody has started a hospital. We have a constitution that says government is a continuum. Yeah. But the next person comes, doesn't complete what is supposed to be continued, and then comes out with a massive thing like 88 hospitals and then moves to 111 and starts building. And the 10% who are the kingmakers do not punish them for doing those things. So you have things like what happened. I remember there was a time that I think multimedia and some people were trying to get Confanoche a neonatal, and a building that had been started 40 years ago had to be raised down.
Yeah, the maternity unit. Yeah.
Yes, that is money just gone down the pan. And so it's just crazy. And we seem to be doing it. And that's why I said in the lecture that the first thing we should do is to fight to devolve health leadership from the executive. Because another thing that is worrying in all that is, let's even say that you've appointed from a small pool. They need security of tenure to plan, because health outcomes take between minimum 5 to 20 years to manifest itself in any population. You take them, and their contracts are more or less tied to the executive. So, for example, the president can wake up this morning and say he sacked the chief executive of Kolebu Teaching Hospital, and nothing can be done about it. He can say the director general of the Ghana Health Service is gone, and nothing can be done about it. But more importantly, because of the transitional provision, anyone who is appointed by the executive his tenure ends with the executive. So you find a situation where technically all our teaching hospitals, the Director General of the Ghana Health Service, and any other health affiliate that was appointed by the president gets truncated on the night of 7th of January.
Yeah.
What madness is that? What, I mean, how can you say so? Unless the new incoming person says, okay, I'm going to maintain these people until I've done my own appointment. The minute the president leaves, the door is shut, midnight. That's it, your job has ended. Meanwhile, we are expecting to get health dividends in maternal mortality that will take 10 to 15 years. I mean, how can we even think so much backwardly? And I wouldn't mince my words. We are thinking so backwardly, and we want to get transformational outcomes. It's not going to happen.
Well, this is how this conversation is going to go. We're certainly going to point out what is wrong with what we're doing and see how we can straighten it up. Because actually, every mistake we point out is human lives. Everything that is done wrong is the effect is a human life or human lives being lost. We can't afford that. Now, I want to illustrate the effect of all those numbers you shared. This is a text message that came to me this morning from Rachel. She says, I almost became a young widow a year ago. My husband had an emergency and we went to a hospital in Tema. I'm not going to mention the name of the hospital. By 4 a.m., an injection had been administered. The doctor told us to wait 15 minutes after the shot for observation and then we could go home since the emergency would have passed. So we just sat at the OPD to wait. Guess what? Within 5 minutes of taking the injection, he blacked out. I started screaming for help while trying to resuscitate him. The doctor came over and helped me take him to the emergency ward. Now, do you know why he went off? The injection was an overdose, according to the doctors. So if he had been alone, sitting at the OPD, they would only have realized that he was dead. I would have been called and told my husband died of unknown diseases because they wouldn't own up to their error, and there would have been no witness to know what was administered. So I just want you to cast your mind through a hospital. The various places at which an error like this could easily happen. The various points at which a person could die with no accountability whatsoever, with no repercussions whatsoever, whether it's the OPD, the dispensary, the wards. I mean, this could happen anywhere, in any hospital. Why is our healthcare system so fraught with weakness?
Thanks, Kojo. I think I tried to answer that question in the lecture. It goes down to leadership. Even at the start of this conversation, I said that. Anyone who was at the lecture would have heard my colleague William Ofori also state the fact that 90% of our health facilities don't even have standard operating procedures with which they work. And it goes down to leadership. It does, because if the leader has a secure tenure, then they can plan to put these processes in place, and then they can hold people to account based on the processes that are in place. Because you have a procedure, and if the procedure is flouted, then you can do an assessment of how the procedure was flouted and how probably an error had occurred, because errors would always occur in healthcare, but you try and minimize it and learn from them. So unless we solve that leadership conundrum, because the first thing is you are appointing a leader. The leader, you see, and that is why I go back to leadership. You appoint a leader first. That leader then appoints subsidiary leaders at the lower level. So let's say you appoint a Director General of the Ghana Health Service. He would appoint other directors, regional directors, district directors, you name it. If the person is so inclined that they are appointed because of political loyalty, what do you think would happen to the subsidiary appointments? Would they be by meritocracy or they would be by loyalty? So if they are by loyalty as well, then even that pool I was talking about is getting even more smaller because the pool from which you're pooling your health human resource at a leadership level is not competitive enough. And once they are not competitive enough and they get in, we are all human. The mentality with which you govern is you also want to find loyalty in the institution you've been asked to run. And once these threats run down the health leadership chain, you are bound to have poor outcomes. I've not seen any health system I've studied where loyalty is the major parameter by which leaders are employed.
You gave some comparative statistics. You talked about other countries. You gave examples of other countries: Rwanda, Senegal, Liberia, and you compared our numbers to theirs. And you talked about our maternal mortality as well as our child mortality, infant mortality, and then our life expectancy. And it was quite clear that the countries you chose have all performed better, well, apart from in one matrix, Liberia, than we have. Okay, we have spent more money than they have, but they have got better outcomes. First of all, help us understand why you chose those countries for comparison, and also why we are throwing money at the problem, but it's not fixing it.
Yeah, that's an interesting question. You see, when I sought out to put the lecture together, I asked myself one question. If you look at our health outcomes, there's organic growth. No one can run away from the fact that there have been improvements in the last 30 years. But the question then became, could we have done better? So then I looked at our discourse when it comes from political narrative as to why we always find reason to more or less downplay our underachievement. And I found out that the major driver these days is COVID. Everything is about COVID, and we've not recovered from COVID.
Yeah.
So I was like, okay, COVID was a global pandemic, but we still find reason when we are having conversations to blame COVID for everything when we underperform, as though the other countries we're being compared with did not have COVID. So I said, okay, I'd make it worse for the other countries and give Ghana a handicap. So I went for 3 countries, all of whom had had civil wars in the last 30 years, and brutal civil wars. And they should also have had another global pandemic apart from COVID. So I selected countries who were ravaged by Ebola. So those countries, to start with, were starting from a lower base. They were investing less. They had been hit more than we had ever been hit over the last 30 years. So they had no business competing with us when it came to health outcomes. And that was to just shut the narrative around COVID. So no one could say, oh, this is attributable to COVID. So that was the baseline. And for me, that was very, very important. So that was part of my methodology, that the comparison should give Ghana an unfair advantage. And so you realize that I did that again with another country that's not in Africa, Singapore, and said, where is Singapore now and where is Ghana? And Singapore is the best health system in the world based on Statista. So I said, where was Singapore in 1960? You look at it, and in 1960, Singapore had 1.6% of its population over the age of 65. Ghana had 2.96%. So our health system, when we became a republic, was actually keeping us living longer. It gave us better longevity than Singapore. By 1970, 4 years after Nkrumah was gone, Singapore had caught up with us at 3.1%. So both health systems were given similar longevity. Then you bring it to 2022, and while Ghana has gone in how many years, from 1970 to 2022, which is 52 years, had gone up from 3.1 to 3.44%. So we had increased the percentage of our population that lives above the age of 65 by 0.43 percentage points. Singapore had moved from 3.1 to 15.29%. So I asked myself, on what basis then are we using COVID as an explanation? Did Singapore not have COVID? Did Rwanda not have COVID? Did, Liberia not have COVID? And did Sudan not have COVID? So that is the reason why those selections were made. And I use a Singapore example to show how badly we have lagged behind. Because in 1960, Singapore had no business comparing itself to us. If you go reading from third world to first, Lee Kuan Yew talks about certain aspects that he learned from Ghana. Yeah. So why do they now have 15+% of their population above the age of 65 and we have 3.44%? And you see, that throws in a number of things, because people are contributing to pension schemes that are supposed to give them, say, a lump sum when they retire at 60, and supposed to pay them something on a monthly basis for another 20 years that they live. Truth of the matter is, our life expectancy at birth under the prevailing circumstances is 63.8 years, which means majority of the people are going to be dead in 3.8 years anyway. And they are contributing, so they are not going to benefit from about 16 years of what they are contributing. So all these things bring a nuance that we need to have a bigger conversation about our health system and even our pension schemes and how they are designed and other things. But we are having conversations and say, oh, we improved by 6.9%, so we've done well. And that is what the politicians want to tell us. So what they are doing is, oh, under the NDC, we improved by maybe 3.3%. And as we improved by 3.5%, we did better than them. But that is a race to the bottom. And that is a race that we need to move ourselves away from. And that is basically what that was about.
Now, we've thrown a lot of money at the problem compared to the other countries that you cited. One would have thought, I mean, these are resource problems. This is a third world country. There's resources we don't have. We can't pay doctors. We can't build hospitals. We can't buy medicines. That's it. So if we are putting money in, why are we not getting better outcomes?
Okay, so you have to look at health this way. Globally, the country that throws the most money at a health problem is the United States. But the country that has the best health system is Singapore. So leadership is key. You understand me? If you look at the statistic table, the top 20 countries with the best health systems have some of the most robust leadership models and based on meritocracy. You've lived in the UK, Raymond, you've lived in the UK. You would never hear that the chief executive of the NHS or NHS improvement is being appointed because Rishi Sunak said, oh, I like this guy in the Conservative Party, he's a good doctor, so he can go and run the NHS. No. It is advertised, and it is advertised even before the incumbent who is about to leave has left office. People then apply for it based on their competence. There's then a search party, sometimes even not from the NHS itself, but sometimes they go for recruitment agencies who would do an interview or an assessment center and come up with the best candidate. That best candidate is then given a contract based on the health strategy of the UK, based on the current prevailing health outcomes and the expectation of an improvement by a particular proportion. But what do we do in Ghana? The minute the president goes, everyone goes, and we get new people in. I dare anyone to say, go show me the appointment letter of any health leader in any teaching hospital which has key performance indicators. We all see the appointment letters because normally they are made public and they'll leave them.
Congratulate them.
Yes. Have you ever seen a key performance indicator which says, I'm appointing you to this position as chief executive of Kolebu Teaching Hospital, and I want you to decrease mortality from maybe orthopedic surgery by X, or to decrease maternal mortality in the hospital by Y? No. So the person is congratulated and given a job for which they are not going to be held to account. That is crazy. And we need to start talking, because the level of craziness is what's manifest in the poor outcomes. So it's got nothing to do with the leaders. It is how we're choosing the leaders and how we are not giving them tasks to complete. And we seem to think it is normal. We just seem to think it's normal. I mean, all of us sitting here, I'm quite sure you'll not be given a job, Raymond, and told, oh, you can go in there and go and work. There are KPIs. At the end of the year, you'll be reviewed not against the loyalty or the contribution to the political party that put you in there, or how many health activities you've organized for party loyalists, but on those key performance indicators. I dare anyone again to show me any leader in our health system who has KPIs, and to show me by how much they have improved the KPIs, and to show me who has held them to account, whether there's been a performance review of these KPIs.
I want to ask something. If the president, for example, the president's child was sick, and there was a choice of two people to operate on this child to save their lives. One of the surgeons belongs to the president's party. The other one is the best surgeon in the world, but belongs to the opposition. I have no doubt in my mind that the president would choose the one from the opposition because it's his child's life at stake. But they still make these appointments based on loyalty. Is the problem the fact that our leaders are not subjected to our healthcare system? They are not at the mercy of our healthcare system. Is that why they are able to make such, in your words, crazy decisions about its leadership?
You see, I struggle when people tell me that our leaders are not subject to our health system. They're actually subject to our health system, but they don't know. The truth of the matter is this: for management of their chronic ailments, because whether you like it or not, when you get to a certain age bracket, you would have chronic diseases and you would need medical checks and other things. They can go abroad and do it. And we hear it. We hear the speaker is going here, the president is going there. We hear it. It's announced. So it's not hidden. It's public knowledge. That's fine. You can go and do that. But if you listen to the speech, when in 2015 my mom was diagnosed with endometrial cancer, the issue was to fly her abroad. But there were other complications that prevented her from being flown abroad. So she had to deal with the health system, even though we had the resources to take her out. But that is actually the reality, because we were here when a president, in an emergency like that, was subject to the health system. We've seen a number of prominent statesmen not being able to be flown out. We've seen a vice president. You understand me? So if it is very naive if they think that they are not subject to the health system, the dangerous part for me is that when they are subject to the health system, they are their most vulnerable. And that is even scary. So it is even more important for them to fix the system, because they use other health systems that are thriving, that are well designed for their routine stuff. But those health systems would not be available for them for their emergency stuff. And most often than not, it's the emergencies that take you out, not the routines.
Indeed. Kwame Sarpong Asiedu is our guest. He's the Democracy and Development Fellow for Health at the Ghana Center for Democratic Development, CDD Ghana. We're talking about his seminal public lecture, which was delivered on Monday, about the health dividends that we are or perhaps are not reaping in this Fourth Republic. So far, so dismal.
Very wonderful conversation that I cannot miss out on. If you listen to the lecture, and I was wondering how you chose those countries, the Liberias, the Rwandas. Now that you have explained, it gives a very different perspective to it. What we are discussing today is that we've been pretending to be doing very well, but compared to countries that have been doing extremely terrible things in times past, they've been through a lot. We do not have the excuse to repeat COVID and the other things that we'll be repeating consistently in this country. You know, that's our biggest excuse, right? For finances, it is. In fact, there was a time that, who said it? somebody said that even our inability to hold press conferences by the Ministry of Information or meet up their targets were because of COVID and its related factors. Even for the year before. I mean, you would think of it and come to the conclusion that we have for so many years refused to be in Nkrumah's standard that we can manage our own business. Because the years you refer to, before 60s, 70s were doing well. The people that were beating the Singapores of this world was in the 60s and the 70s. Immediately after that period, something dramatically changed in this country. We became poor performers. And we are so happy in that state. We entrench it. We make it consistently the case. I mean, there are people talking about, there's a point you are going to raise, Kojo, about a new industry which sits on Snapchat and all the social media handles. Never regulated. Nobody cares about them. But they are the ones feeding an entire generation with aphrodisiacs. They are the ones feeding with drugs. Now, even cosmetics, they do it at home, show you how they do it on Snapchat and on social media. And they are destroying human bodies, kidneys, livers, and nobody cares.
And the regulators are browsing.
Yeah.
They are browsing.
They see them.
They see it. Yeah.
Sometimes they are even patrons.
Oh, my God. Our guest is Kwame Sarpong, Asiedu. He delivered a lecture on Monday about the health dividends of the Fourth Republic, or the lack of them. And we're trying to figure out what the way forward ought to be. As for the problem, I think it's obvious. We can all see what the problems are. The symptoms are the things you experience. The no bed syndrome, the no ambulance syndrome, the no oxygen syndrome. The lack of basic things that are needed to save human lives. Those are the symptoms. But of course, the solution has to come from leadership. But that's the question I have on my mind. Leadership, which would include and encompass regulation, seems to be asleep. Raymond gave a perfect example of the kinds of concoctions that Ghanaians can quite freely shovel into their systems and become a burden on the healthcare system as a result. I mean, why is nobody thinking preventive medicine in Ghana?
Kojo, it's interesting because in the lecture, I talked about it and I would read. I said, then there is the forgotten populace who rely on traditional medicine, priests, fetish, juju men, malams, and outright quacks. Their percentage is not clearly known, but is known to be significant. And why do I say that? You see, when they mix these products, even people with professional qualifications are buying from them. And that is why it's they are a forgotten populace. They exist, but leadership and regulation behaves as though they are just in the ether. You see, and so it's become a free-for-all. People will be taken to a sorry fear for something that has to be. And when you have an unregulated space like that, yes, you would have people who would take advantage of it. And that's why you're saying that they are selling all these things on Instagram. But the unfortunate thing is, especially for those who cannot afford conventional healthcare and seek healthcare through these unorthodox routes, when they have the so-called liver and kidney damage and they get to the hospitals to start it, if it's dialysis, like you were saying, when they are back of the queue because they cannot even afford it. You see, and unfortunately, many pass away. But nobody is doing anything about it. All you need to do is to go to any of the bus terminals or town, and you see them hawking their wares. Or you need to go to a spot anywhere, and you see all these concoctions with alcohol, and people are drinking. You ask a person, what does it contain? I have no idea. And you see, we are laughing, but these are outrages that are happening under our health system. It's outrageous that we live in a democracy and not a banana republic. This is a democracy. And democracy leverages on the rule of law. What rule of law is allowing these people to do all these things? What's the rule of law here?
Do you think part of it is cultural? Do you think that perhaps we have, even in the Ghana Health Service, at the top of its leadership, or in the Ministry of Health, or at the Food and Drug Authority, at the top of their leadership, do we have people who fundamentally all believe that these roots and stems are potent, they are not harmful because they are organic, and these are the things that our forefathers used to cure themselves, so just leave them be?
You see, I don't believe so, because it would be disingenuous if you get to that level with your level of education and you believe that.
But they are the ones buying.
No, but
buying the medicine.
But, Kojo, that's the point I made. If I referred to the fact that as a pharmacist, I've seen a lot of research done by leading lights who predate me, like Professor Kwame Sarpong of this world, and Samuel Juma Beduma, mentor JSK Yim, and currently the likes of Professor Charles Ansah, Professor Yensu, who are doing a lot of research into herbal medicine in Ghana. And so we know that there are some herbal medicinal products that have efficacy against certain things. But even then, they should be a dose.
Yeah.
They should be extracted properly and all that. So I wouldn't think that those people would then suddenly think that, oh, our forefathers were using it and therefore it becomes free for all. But then, and that is why I said down memory lane, when we start saying, oh, is it cultural? What cultural dynamic are we talking about? Doesn't Rwanda have a culture? Are they not blacks as well? Do the Sudanese not have a culture? For that matter, Liberia or Kenya. So and that is why I said we get ourselves steeped into these narratives that we are some different crop of people, 31 million unique human beings who are in outer space, devoid of anything else, and all the comparators are within the 31 million people. We do not compare what good looks like. How is Rwanda doing it? Do you go to Rwanda these days and see churches all over the place to say, oh, they've taken someone who has either a mental health issue or something to Asorifi? You think Kagame will stand for that? He'll shut the church down. Is it happening in Ghana? Yes. If you go there to try and shut the church down, you'll be told, touch not the anointed. What anointed? In a democracy. It just must not be allowed to happen. And that is why, for me, I'll continue harping that it is a leadership problem. We need to get some serious leaders into most sectors in this country, but more importantly, health, because health is wealth.
I've realized that it's almost impossible to convince a leader to do something different unless it will involve procurement. So what can we do to make our leaders actually start fixing these gaping holes in our healthcare system?
What the first thing we can do is to ensure that those aspects of our constitution that require appointment based on loyalty are expunged. Because, look, and that's why I say sometimes when you're having these conversations, it becomes like a broken record. When we went into this democracy, we were here before Kumpreko and all that, and everyone said, oh, this constitution was made for Rawlings. It was made to make him a democratic emperor, so to speak. And they were like that. So you have thought that people will change it. Afterwards, we've had President Kufuor. It didn't change. We've had President Atamils. It didn't change. We've had President Mahama. It didn't change. And now we have President Nana Akufo-Addo. And all of them have used the thing that they were criticizing as an imperial precedent to appoint people based on loyalty. So it tells me that if we need to protect them from themselves as citizens. And the only people who can do it is the middle 10%. Because as it stands now, the 44 to 46% of NDC are sitting waiting patiently, hoping that 2024 the tables would turn and they would have their shot at it. The only way we can do it is to prevent them from harming themselves and harming us, and saying those aspects should be taken out of the constitution.
So how do we do this? How does the middle 10% mobilize in a way that actually ensures that these people do what they dictate?
You see, this is the thing. The two political parties are well resourced. And so they do everything to prevent a third force from coming. In fact, if you try to become a third force, they gang up against you and make sure that they destroy you, because it's not in their interest to have a third party. Fortunately or unfortunately, a lot of people in this 10% belong to the middle classes because they are the ones who tend to shift their vote. We need to have more of these conversations with them. We need to put the figures. Like I said, that the former president was right. We have very short memories. So we've become oblivious of a lot of these statistics that stare us in the face. Like some people would say, the best way to hide anything from the Ghanaian is to hide it in plain sight. Because if you put something in plain sight, the Ghanaian is not going to look at it. Whereas if you hid it in some obscure place, he would go and search and find it.
Yeah.
So the data that's in plain sight, we are not even looking at it. We need to have the conversation with that 10% for them to see the data, and they need to start asking questions. But more importantly, the narrative that, oh, the person can stay for 8 years, we need to start breaking it, because the 10% are the kingmakers. If after 2.5 years they realize that you are not doing what you have to do, year 4, they kick you out. We need to make these conversations around our transitional provisions and Article 71 and the imperial presidency and the president appointing everyone within Lily become a conversation at the next election. Are you going to get rid of it? Similar to what we've made Article 71 become a conversation that everyone is having. And if you commit that, when I come, I'm going to look at these things, and you come and you don't look at them, or you start appointing based on loyalty, then the 10% should realize that this guy's not going to help us. And then we need to have a way to kick them out. And that is the only way we're going to get this done.
So, I mean, let's walk through it, okay? Let's start with things like how we manage our actual hospitals, so the primary care delivery, okay? Every president will come and appoint his people at that level. But really, in order for a hospital to do better or worse, there's so many factors. It's going to be down to the expertise, that is available to them, so the personnel. It's going to be down to the equipment, and then, of course, leadership crowns it all. So what would be the strategy? What would you advise this middle 10% to demand? Let's itemize the things that they should demand from the next leader of this country to improve primary healthcare delivery.
The first thing they should demand is a merit-based system for appointing health leaders. Because if you appoint them based on merit, they are now going to appoint the next level of leaders, and they would do it on merit as well. You understand me? And the more merit starts trickling down, it will trickle down to standard operating procedures in the hospitals. And people having performance contracts that hold them to account. In fact, you go to certain countries and you go to hospitals, and even customer service is part of a nurse's performance contract. How you talk to patients is part of a nurse's contract and performance contract. Even feedback that you receive based on service users is part of performance contract. Can you show me any nurse in Ghana that has a contract which says these are your key performance indicators? And we look at these things, and why is it not happening? It's not happening because the person sitting right at the top has no contract like that. So we need to demand a merit-based system to start with, and ensure that the people have a guarantee security of tenure. The president shouldn't have a bad dream and say, I sacked the chief executive of the Ghana Health Service, or for that matter, I sacked the Kolebu chief executive. That should not happen. You should be appointed for a tenure with key performance indicators that are reviewed at certain points during your tenure. And you should probably then have a renewal mandate based on your performance. So if we have that secure tenure, then we can then ask them for medium to long-term plans.
Right.
And it's these medium to long-term plans that are going to deliver the outputs that would be leveraged to get the outcomes. But if we do these start-stop things in 2.5 years, ask yourself, since this president came, how many chief executives of Kolebu have come and gone? How many chief executives of Komfanochi Teaching Hospital have come and gone? In a 6 to 7 year period. That's ridiculous. You see, it's only in this country that I see that we have a president who can appoint the chief executive of Cape Coast Teaching Hospital, who Temale, Komfanochi, Kolebu. What's this? And then he also has more people on their boards because of presidential nominees. So the people who are supposed to hold the chief executive to account are invariably also appointed by the overall chief executive. You go in there and it's like a class of friends.
Yeah.
And that is what has to change.
So, okay. So, yeah, I think we've all seen the pattern where leadership is changing positions from jobs to rewards.
Yeah.
So, if it's a reward, then once you get there, then there's no job to be done because it's a reward. So, you just go and then you reap the benefits. So, today, if a Ghanaian walks into a hospital, I want to, you've talked about it from the top end, okay, the solution coming from the top end. I want to look at the bottom end too. If a Ghanaian walks into a hospital, is there something that he can do to ensure that the care he's given is better?
You see, Kojo, again, in the speech, I answered it. I said, look, something like the NHIS, which would be the best trump card for this person because I've got a national health insurance scheme and it should give me some services when I go into the hospital. Anyone here who has an NHIS card, can you tell me the drugs that the NHIS card qualifies you for?
No idea.
So you don't know the drugs that the NHIS card qualifies you for?
You discover it at the pharmacy.
Yes.
And it's
you take the pharmacist's word for it.
Yes,
Whoever
yes,
is
yes.
behind the counter, they
and
may
they
not be a
choose what to
pharmacist.
tell you
Okay.
at what
So
time.
you don't
Sometimes
know.
they come in that, oh, it's even covered, but it's finished.
No, so you don't know. You've gone for an insurance,
Yeah.
but you don't know what the premiums are. You do not know what that card gives you. Do you know the surgeries it covers?
No idea.
So, if we, and that's a question I ask in the lecture, if we were to defy the odds of our life expectancy of 63.8 years and live to my father's age of 87, would I know the monetary dividends that as an octogenarian I need to get from the NHIS to keep myself alive and well, assuming I don't have kids or I didn't secure my old age well enough to take care of me. Those are the things that the citizens should do. And you shouldn't do it. And that's why I didn't address going to the hospital, because by the time you go to the hospital, it's too late.
Yeah.
When I was training in England, one thing they told me, Professor John David Smart told me was, he said, look, Kwame, one thing you have to realize as a health professional, whether you are lecturing, whether you are a researcher, whether you are in community practice, is that nobody comes to you by choice. They come by compulsion because the person is unwell. And any human being would tell you that they don't like to be compelled. So the fact that you're being compelled, at that point, you're under duress. That is not the point to be seeking what that card gives you. And unless and until we start seeking it whilst we're having this conversation to say, how can the NHIS tell us that we have a card, but we don't even know what it's worth? And so they need to tell us now. The public education needs to start. If we don't do that, and that is where holding to account starts from. If we don't do that, then we go to the hospitals and we think that that's where we're going to find out or do something to benefit us, then we're joking.
I think that is a perfect point on which we can bring a pause to our conversation. But it's a pause. It's not an end. Because this conversation, dear, it has to go on, and it has to go deep and down to every level for every Ghanaian to find themselves in it. That's the only way we can effect change. Kwame Sarpong Asiedu, Democracy and Development Fellow for Health at the Ghana Center for Democratic Development, CDD Ghana. I can't thank you enough for joining us this morning, and of course for your seminal lecture that you delivered on Monday.